Hi, this is Dr. George Rogu from RVK Pediatrics and Urgent Care. Another month goes by and another student rotates through our office from NYIT.com, the medical school on Long Island. And today we're going to have Dr. Jacob, who some of you may have already met throughout the office because he was with me all month. And he's going to speak to us about a nice topic, neonatal malformations, some scary things that you see when the child is born in the newborn nursery that ultimately get surgically corrected and life moves on. So Dr. Jacob, thank you for being with me this month. I hope you learned something. And remember, every case is a board question, including what we have on this presentation. Take it away.
Good morning, Dr. Logo. Thank you for having me. So jumping right in, we will be talking about neonatal malformations. Here is a list of some of the malformations we will be talking about. Let's just jump right in with omphalocele. So an omphalocele is a midline abdominal wall defect where there is an absence of skin and muscle. The defect is usually covered by a 3-layer membranes. Omphaloceles are either categorized as either non-liver containing or liver containing. Small defects generally can be closed in the first 24 to 72 hours of life. This defect usually happens in the 6th week of fetal development. Omphalocele is one of the most common fetal abdominal wall defects in the United States, with a prevalence of approximately 2 per 10,000 live births. Worldwide, the prevalence of omphalocele is 2.6 per 10,000 births. The occurrence of omphalocele appears to be more common in offspring of mothers at the extremes of reproductive age, in mothers less than 20 years old or greater than 40 years old. The odds of omphalocele in offspring are more than doubled compared to the general obstetric population. This prevalence is slightly higher in Black populations compared to white populations. Omphalocele has also been associated with male sex and multiple births. The prenatal diagnosis of an omphalocele can increase the chance of identifying some syndromes prenatally and provides time for parents to learn about and adjust to the abnormality. Omphalocele is typically diagnosed as part of an obstetric ultrasound examination. Prenatal diagnosis of a non-liver containing omphalocele can be made reliably after 12 postmenstrual weeks. Prenatal diagnosis of a liver-containing omphalocele can be made by transvaginal sonography as early as 9 to 10 postmenstrual weeks. 80% of omphalocele contain part of the liver. The term giant omphalocele has been used to describe omphalocele that contain greater than 75% of the liver. Although the omphalocele may appear to be an isolated anomaly prenatally, a substantial portion of these fetuses will have an associated abnormalities identified after birth. In addition to routine prenatal care, pregnancies complicated by omphalocele are followed with serial ultrasound examinations every 3 to 4 weeks to evaluate fetal growth. Gastroschisis is another abdominal wall defect. It is a full-thickness periumbilical abdominal wall defect. This defect can lead to a variety of intestinal abnormalities because the gut supply can become compromised and because the bowel wall can become inflamed from prolonged irritation. In addition to intestinal abnormalities, other common potential complications of gastroschisis include growth restriction, spontaneous preterm birth, and fetal demise. Growth deficiency may be due to the undernutrition from loss of protein and fluid across the exposed bowel. After birth, the newborn requires special care because of the exposed bowel. The defect must be closed, which can be difficult if the defect is large and other abdominal organs are also herniated, aka they're coming out. However, the prognosis is generally very good. Gene polymorphisms that interact with environmental factors, such as smoking, might play a role in the occurrence of this defect. The prevalence of gastroschisis appears to be higher in areas where agricultural chemical levels in surface water are higher. Gastroschisis has not been associated with a maternal deficiency of any micronutrient or macronutrient. Gastroschisis occurs in every 4 per 10,000 live births. The incidence of gastroschisis is similar in male and female fetuses and is higher in single pregnancies compared to twin pregnancies. Gastroschisis is higher in non-Hispanic white mothers than non-Hispanic Black mothers. An increased possibility of gastroschisis, as well as other fetal anomalies, should be considered in pregnancies with an elevated maternal serum alpha-fetoprotein level, as almost all cases of gastroschisis are associated with this finding. Most cases can be detected by the end of the first trimester, which is 11 to 14 weeks, and certainly in the second trimester. Prenatal detection rates are over 90% as a result of routine ultrasound screening for fetal anomalies. Related gastrointestinal anomalies and problems such as malrotation, atresia, stenosis, perforation, necrosis, and volvulus occurs in up to 25% of cases and may be due to vascular disruption caused by the herniated bowel.
So fortunately, Jacob, these cases are never a surprise. We find out about them prenatally. The parents are aware of the condition, and then the child is delivered at a specialized hospital where there's a pediatric surgeon, and they resolve the condition rather quickly.
Yeah, 100%.
That's great.
And like I mentioned before, it gives the parents time to adjust these prenatal
Correct.
screenings. It just goes to show how important these screenings are.
They look pretty scary, those pictures. And could
Yeah.
you imagine if it was a surprise?
Yeah. Moving on, we're going to talk a little bit about the cleft lip/palate. The oral cleft is one of the most common craniofacial malformations in the newborn. The three main types of oral clefts are cleft lip alone, cleft palate alone, and cleft lip with cleft palate. In the United States, the prevalence of cleft lip is 3 per 10,000 births. Cleft lip with cleft palate is 6 per 10,000 births, and cleft palate alone is 6 per 10,000 live births. Race, ethnicity, maternal age, and fetal sex affects the prevalence of these conditions. Maternal age greater than 35 years has been associated with an increased risk of oral clefts in offspring in several different populations. The occurrence of this condition is a genetically complex event with gene-gene and gene-environment interactions. Over 30 candidate genes have been identified. There are some known drugs that can cause cleft lip and palate. These drugs include the anti-seizure medications known as phenytoin, sodium valproate, as well as the folic acid antagonist methotrexate. Some antidepressants, such as ondansetron, cause this condition as well. Fetuses with oral clefts should undergo careful full-body assessments for additional structural abnormalities, which are common and vary by type and location of the oral cleft. Associated anomalies have been detected in 28% of fetuses with both cleft lip and palate. The initial focus of post-delivery newborn care is assessment of the infant's airway and suckling ability. Infants with cleft palate generally cannot generate sufficient negative intraoral pressure to suck milk effectively from bottle or breast, but often can be bottle fed with formula or expressed breast milk with the use of adaptive feeding equipment such as a squeezable bottle. This is really important because children with this condition will have growth restrictions because they're not able to properly feed if not given the right interventions. Primary lip repairs can be undertaken at 3 months of age, with palatal repairs around 6 months. Additionally, surgeries such as speech and orthodontic therapies are often needed. Moving on, congenital diaphragmatic hernias are a developmental defect of the diaphragm that allows abdominal viscera to herniate into the chest, thereby compressing the lung and interfering with normal lung development. With the increased compression of the developing lung by the herniated abdominal contents, the lung development is halted. Diagnosis can be made prenatally with ultrasound examination. Among infants in whom congenital diaphragmatic hernia is not diagnosed in utero, the diagnosis is made by chest radiography, such as X-ray. This usually shows herniation of the abdominal contents. Postnatally, infants with congenital diaphragmatic hernia often present with respiratory distress in the first few hours or days of life. This spectrum can vary from the more common presentation of acute respiratory distress at birth to minimal or no symptoms, which is observed in a much smaller group of patients who present much later in life. In patients who present as neonates, the degree of respiratory distress is dependent on the severity of lung hyperplasia and development of pulmonary hypertension. Adrenal insufficiency is reported to be a common finding in infants with congenital diaphragmatic hernia. Physical findings of a patient with this condition includes a barrel-shaped chest, a scaphoid-appearing abdomen, and absence of breath sounds on the same side where the hernia is. In patients with a left-sided congenital diaphragmatic hernia, the heartbeat is displaced to the right because of a shift in the chest. Prenatally diagnosed patients are intubated in the delivery room. In patients with only mild symptoms on minimal support, in which there was no evidence of pulmonary hypertension or pulmonary hypoplasia, repair is typically undertaken at 48 to 72 hours of age. Even after surgical correction, complications can arise. Subsequent failure to thrive has been reported in survivors with congenital diaphragmatic hernias, which extend into late childhood and adolescence. Chest deformities include pectus excavatum, pectus carnatum, and scoliosis, particularly in patients with repaired large congenital diaphragmatic hernias. This condition is associated with survival rates of 70 to 92%. Factors associated with decreased survival include prematurity, cardiac abnormalities, persistent and severe pulmonary hypertension.
Diaphragmatic hernia, I remember had seen this once as an intern way back. And it's a very scary situation because the baby goes into respiratory distress and you don't know why. It was scary for the doctors, for the nurses, for the parents. And the reason we didn't know about it was because the patient had no prenatal care. So if they would have only went to the gynecologist for prenatal visits, people would have known about it and it could have been prepared. Ultimately, that child did very well, had surgery, but it was a stressful night for everybody.
I'm sure. And I'm sure I can't imagine what the parents would go
Oh,
through.
yeah.
So moving on, a hydrocele is a collection of fluid between the two layers around the testes and spermatic core. Hydroceles are believed to arise from an imbalance of secretion and reabsorption of fluid. Idiopathic hydrocele is the most common type and generally arises over a long period of time. Inflammatory conditions of the scrotum, such as epididymitis and torsion, can produce an acute reactive hydrocele, which often resolves with treatment of the underlying condition. Hydroceles range in size from small, soft collection that still allow palpation of the scrotal contents to massive, tense collections of several liters that make examination impossible. Pain and disability generally correlate with the size. Hydrocele fluid in the scrotal sac transilluminates well. What that means is you can shine a light to it and you'll be able to see the light illuminate the sac. This differentiates the process from a possible hematocele, hernia, or solid mass. A hematocele is a collection of blood in the scrotum. A scrotal ultrasound should be considered if the diagnosis is uncertain, since a reactive hydrocele can occur in the presence of testicular neoplasm or acute inflammatory scrotal condition, such as orchitis or epididymitis. Most hydroceles do not require intervention. Treatment is only indicated in patients who are symptomatic with pain or pressure sensation, or when the scrotal skin integrity is compromised from chronic irritation. For asymptomatic patients with hydrocele, there is no need for routine follow-up. The most common surgical procedure is excision of the hydrocele sac. Simple aspiration is generally unsuccessful because of the rapid reaccumulation of fluid, but may be effective if combined with instillation of a sclerosing agent, such as tetracycline or alcohol, into the sac. The potential risks of this approach are a low incidence of reactive orchitis or epididymitis. Orchitis and epididymitis refer to inflammation in the scrotal sac. Because of the potential risks, this might make open surgery more difficult because of the development of adhesions between the hydrocele sac and scrotal contents. Cryptorchidism refers to testes that is not within the scrotum and do not descend spontaneously into the scrotum by 4 months of age. Most cryptorchid testes are undescended, but some are absent due to non-formation. True undescended testes have stopped short along their normal path of descent into the scrotum. They remain in the abdominal cavity, or they may be palpable in the inguinal canal just outside the external ring. Between 2 and 5% of full term and approximately 30% of premature male infants are born with an undescended testes. It goes without saying that this condition only affects males. Cryptorchidism usually is an isolated finding. However, it may occur in association with endocrine disorders, genetic syndromes, and morphologic abnormalities. Clinical features of cryptorchidism include an empty sac and a hypoplastic or poorly irrigated scrotum. Poorly irrigated means that there is the scrotum appears smooth as opposed to not smooth. Inguinal fullness may be present. Most congenitally undescended testes descend spontaneously by 4 months of age. Some testes that are fully descended in infancies or later in childhood, typically between the ages 4 and 8 years, ascend to an undescended position, which is really interesting. So you could have a newborn that's completely fine, his testes are descended, but later on in life, they could go back up. Evaluation of cryptorchidism typically includes history and physical examination. Imaging and laboratory studies are not routinely warranted, but may be necessary to exclude associated conditions. The testicular examination in the infant and young child requires 2 hands. The hands may be lubricated with surgical lubricant or warm soapy water if necessary. One hand is placed near the anterior superior iliac spine, which is an anatomic landmark located in the front of the body, and the other hand is put on the scrotum. The first hand's fingers are swept from the anterior iliac spine along the inguinal canal to gently express any retained testicular tissue into the scrotum. A true undescended or ectopic inguinal testes may slide or pop from the examiner's fingers during this maneuver. A low ectopic or retractile testes may be felt by the second hand, as a testes is milked into the scrotum by the first hand. The diagnostic approach to cryptorchidism depends upon whether the testes is palpable or non-palpable. Cephalohematoma is a collection of blood caused by the rupture of veins over the parietal or occipital bones, which present a swelling that do not cause suture lines. The swelling may or may not be accompanied by discoloration. It rarely expands after birth and does not generally cause significant blood loss. Generally, it just looks like the baby has an abnormal bump on the head, a very big bump.
Little cone head.
Yes.
It looks pretty scary for parents. And, reassurance that it will go away is usually the therapy. I'm very lucky to tell them that my son had it when he was born because he had a vacuum extraction. And, it goes away, I assure them.
Cephalohematoma is estimated to occur in 1 to 2% of all deliveries and is much more common when forceps or vacuum delivery is performed. Ultrasound is useful for calculation of the fluid collection. However, it may not clearly depict the location of the hematoma relative to the scar sutures. Imaging with computer tomography, CT, or magnetic resonance imaging, MRI, will confirm the subparietal location of the cephalohematoma and can also be used for evaluating the presence or absence of associated osteomyelitis. The majority of cephalohematomas will resolve spontaneously over the course of a few weeks without any intervention. However, calcification of the hematoma can occur with a subsequent bony swelling that may persist for months. Significant deformities of the skull may occur when calcifications or ossification of the cephalohematoma occurs. Case reports have demonstrated successful surgical excision of these calcified or ossified hematomas. Other complications of cephalohematoma include infection and sepsis, with E. coli being the most commonly reported causative agent. Infected cephalomatomas present as red masses that may have expanded from their baseline size. Needle aspiration and culture of the hematoma are considered to be mandatory to diagnose infection for suspected cases. Osteomyelitis is a reported complication of an infected cephalohematoma. In these affected infants, treatment includes incision and drainage of the abscess with debridement of the necrotic skull and a prolonged course of antibiotics.
Yeah, it's a very common event, but everything you described sounds very scary. But in my career, they all get better. They all get better. The surgical, those are the rarities. It can happen, of course, but it's very, very rare. Okay.
Polydactyly is one of the most common congenital limb anomalies. It can occur as an isolated finding or an association of other congenital anomalies. Polydactyly is more frequent in Black people and has a prevalence of 1.3%. The birth defect can result from autosomal dominant trait. Polydactyly is linked to a determined set of genes. A careful family history should be obtained when evaluating a child with polydactyly, particularly in Black people, since penetrance for this trait can be incomplete. Supernumerary digits of the hand are most often found on the outside surface of the pinky. They may be small, pedunculated, papulars, or fully formed digits. Treatment is surgical. Many times, treatment is just stopping the blood supply to the affected region in order for the extra digit to essentially die off due to the loss of nutrients and blood. I want to thank you all for participating with me in this discussion. If you have any questions or concerns, please feel free to reach out to me at this email. Thank you so much.
Yeah, thank you, Jacob, for rotating in the RBK Pediatrics office. I hope you learned something. There are many board questions, even on this presentation. Almost every single slide was a board question. So I'm sure you're going to do very, very well on the boards. Thank you very much.
Thank you.